Good morning, everyone. Thank you all for coming. Today is May 27th, 2022. And we are going to start our in-services. The first one today is on peripheral arterial disease, taught by Macy, and I'm going to turn it over to her.
All right, thank you, Dr. Baldwin. So as Dr. Baldwin said, my name is Macy Worley, and today I'm going to be discussing peripheral arterial disease with you, which is further going to be denoted as PAD in the PowerPoint. So by the end of this presentation, I hope that you'll be able to take away a few key things. The first one being able to explain what peripheral arterial disease is and how the condition is identified based on the patient's risk factors, signs and symptoms, and physical findings. And also, I hope you'll be able to discuss both the pharmacologic and non-pharm treatment options for patients presenting with PAD. So we're first going to begin by discussing what is PAD. So PAD is commonly described as a circulatory dysfunction in patients in which their arteries are progressively narrowing over time. And so this narrowing is going to limit the blood supply from the heart that travels to our peripheral limbs, which are mainly going to be our arms, legs, and feet. So as PAD is mostly found and complained of within a person's legs, it can also occur, as I said, in the arms, the head, stomach, and kidneys in some cases. So why we're focused on PAD is because PAD is a disease state in itself that's going to increase the risk of a patient having cardiovascular related morbidity symptoms and mortality, as we'll see that this disease state can interact with other cardiovascular conditions, such as having high blood pressure, high cholesterol, and diabetes to worsen over time. So what causes PAD? So in a patient with PAD, typically their arteries are narrowing because they have a buildup of fatty plaque on the wall of their arteries, which is otherwise termed as atherosclerosis. So as these arteries progressively narrow, they can also become completely occluded as the disease progresses. So this narrowing of the arteries is going to ultimately limit the overall amount of blood and the oxygen supply to the patient's active muscles and cause some of the symptoms of PAD that we're going to discuss. And why we're concerned with controlling our PAD symptoms is because if a patient progresses to an overall occlusion, then this plaque could possibly rupture and lead to formation of a blood clot, which is unwanted. So this image here is shown to illustrate what our normal artery on the left is going to look like. And you'll see that the blood flow is completely open with the artery, so the patient's going to receive adequate circulation with each heartbeat. However, on the right, we see the atherosclerotic artery, which shows on the yellow as the plaque. So you see that it limits the amount of blood that's going to reach the patient's legs and feet. So the prevalence of PAD is very common as it impacts approximately 8.5 million Americans that are over the age of 40 years old. So as we see in the graph, we start to see PAD in some patients around 40, and we see that once a patient reaches the threshold of about 65 and above, that's when PAD is most likely going to be found. And it occurs commonly in both males and females equally. However, we do typically see this disease state, particularly in our African American population, more than others. So what I want to leave you with is that the prevalence of PAD is high. However, the awareness and the diagnosis of PAD is low. And with that being said, we see this because symptoms of PAD can often be left undiagnosed or mistaken for another disease state. So the patient can ultimately be left untreated. So we want to have a quick diagnosis because if the patient's left untreated, then this could lead to limb amputations or possible gangrene, because when a patient doesn't have adequate blood supplied to their limbs, then this is going to lead to dead tissue. So now we're going to discuss what are the risk factors for PAD in patients. So ultimately, progressing age, like we previously discussed, is a huge risk factor, along with our atherosclerosis risk factors, which are going to be smoking is one of the most common, hypertension, hyperlipidemia, and diabetes. So these are the 4 key factors that we're going to look at in our patients and see if we can control them further before we progress for PAD diagnosis. So what are our signs and symptoms of PAD? And our signs and symptoms of PAD can present as what we call claudication, which is simply when the patient experiences pain while moving their arms or legs, completing physical activity, which is going to leave them feeling extremely tired. They're going to feel and complain of aching in their legs or cramping. But one thing to note with these symptoms is that typically in PAD, these symptoms will reside in about 10 minutes with rest. So it's typically the signs and symptoms are going to be exacerbated by activity. And also, one key fact is that about 4 in 10 people with PAD have no leg pain. That is why this disease can often not be caught quick enough. So since the signs and symptoms are kind of harder for patients to recognize when they're early in their PAD disease state, a few physical findings that our physicians can look for, and also for patients to look for over time, is feeling of their pulses in their feet. And as you can see on the right, the diagram shows that we look for a pulse on the top of our foot, or you can feel to the side of our ankle, which we'll discuss further. Also, the patient, if they present with sores or ulcers that they just don't seem to be getting any better, that's also typical for PAD, as well as hair loss, smooth and shiny skin on the legs and feet, or also skin that is slightly cold to the touch, and also cold and numb toes. So these pictures are just going to illustrate some of the milder cases and some of the severe cases. So we're going to see the toenails, we're going to see the ulcer, and bluish limbs. So how is PAD diagnosed? Typically, the physician is going to use what we call an ankle brachial index. And what this does is it measures the blood pressure in both the brachial arteries, which refers to the arm, and it compares it to the blood pressure in the ankles. So as we see in this divide, in the pictures on the bottom, we're going to first measure at rest the blood pressure in the arm, and then we're going to calculate this by dividing it by the blood pressure in the ankle. And so what we look for a confirmation of PAD is a ratio that is less than 0.9. And this is a very good way to diagnose PAD, because patients are not going to have any downtime. This is a non-invasive procedure, so it's very simple and quick. And now we're going to discuss how do we treat PAD. So for our goals of therapy, since our patients are experiencing most of their pain while they're moving, we're going to want to try to increase their walking distance and duration without having pain. And we're also going to want to try to control one's hypertension, hyperlipidemia, and diabetes, as these conditions further worsen PAD. And overall, we want our patients to have an improved quality of life. So we're going to break this up into our non-foreign treatment, which focuses on smoking cessation, structured exercise, and then our pharmacologic treatment can involve agents that are called antiplatelets, possible anticoagulants, revascularization, and optimizing our other disease state medications. So to begin with our smoking cessation, smoking is one of the highest risk factors for diagnosing PAD because patients who smoke typically see PAD present about 10 years earlier than those who don't. So it's important for patient advocates, physicians, pharmacists, that we all, if we know that the patient has PAD and that they smoke, to encourage patients to quit smoking at every visit. Because smoking cessation is one of those things where it's hard for patients to be successful on their first try. However, it typically does take patients about 8 to 10 tries before they're successful with smoking cessation. In terms of pharmacotherapy for smoking cessation, we can recommend agents such as Chantix, bupropion, and nicotine replacement therapy, which can be in the form of a chewing gum, a patch, or a lozenge based on the patient's preference and what they're most comfortable with using. And also below, I've included the NC Quit line also provides free resources to residents for smoking cessation. And now, first, exercise. I want to stress that this, in the guidelines, it refers that we use structured exercise because we want our patients to have an improved functional status, quality of life, and reduce their leg symptoms. But if patients are participating in structured exercise, then we can ensure that the exercise is individualized to their abilities and inabilities. And also, it allows us to make sure that the patient is progressing their exercise in terms of the duration, the intensity of exercise that they're completing at a steadfast state to challenge themselves. So now for our pharmacologic treatment. The mainstay of therapy is generally with antiplatelets, and the most common antiplatelet that's going to be prescribed is aspirin. So the dose based on the patient's disease progression can range from 75 to 325 milligrams, so typically around that 81 milligram tablet. And what this medication is going to do is it's going to prevent the formation of blood clots in the patient. Typical side effects to expect with this medication is going to be abdominal pain, gastric ulcers, bleeding, nausea, and constipation. So our next agent is clopidogrel, and this agent is typically reserved for patients who are unable to tolerate aspirin, but it's also another agent that works to prevent platelets from collecting and forming clots that can further cause a heart attack or a possible stroke. So this medication is typically well tolerated. It can, of course, cause bleeding, hemorrhage, or itching, but it's generally well tolerated. And also, there is a thing that we call dual antiplatelet therapy. And what this entails is a patient could be prescribed both aspirin and clopidogrel if they are at a severe point within PAD, or it could be suggested after a patient undergoes revascularization, which we'll discuss. And also, one final antiplatelet that can be prescribed, we don't typically see it as often, is cilostazol. And what this medication does is that it helps to open the narrowed artery to prevent clotting and to also make walking easier. So this drug is going to help to increase our duration of walking time in our PAD patients. However, some of the side effects accompanying this medication is tachycardia, which is a fast heart rate, palpitations, possible headache and dizziness, and peripheral edema. So the FDA cautions that the use of this medication in patients who have heart failure due to the risk of experiencing the tachyarrhythmias. So that's why typically it's kind of reserved as a third line option. Next, we're going to discuss our anticoagulant. And this drug is called rivaroxaban, which is typically advertised as Xarelto. And it's given as a dose of 2.5 milligrams taken twice a day, along with aspirin. So the patient's going to be taking 2 medications. And what this drug does, in addition to the aspirin, is it also decreases the clotting ability of the blood to further prevent the harmful clots from forming in the blood vessel. So typical side effects, again, are bleeding, dizziness, abdominal pain, kind of as we expect with the other agents. What makes this combination of therapy most attractive is that we have data from the COMPASS trial that shows a 24% reduction in the risk of major CV events in patients with chronic coronary artery disease and/or PAD. So it does have the PAD data. So that's what we're most concerned with. And also, patients with PAD have accompanying, as we said, diabetes, high blood pressure, and hyperlipidemia, which are all cardiovascular contributing disease states. So this is very attractive for us. However, as we would expect, patients are at risk of experiencing a higher GI bleed risk because they are on to medications with bleeding side effects. Also, some patients, they may be candidates for revascularization. And what this ultimately does is it helps to restore the blood flow to the patient's affected area by using either a stent, a bypass, or the removal of particular arteries. And once this is done, as I previously stated, dual antiplatelet therapy may be initiated in the patient, just because sometimes the patient may be receiving a graft material, so it helps keep the material clean and free of blood clots. And lastly, we also want to just make sure that our hypertension medications and our statins are optimized. So for antihypertensives, having a high blood pressure, what this does is it increases the risk of the plaque buildup. And we have data that shows that for hypertension, if we use what we call an ACE inhibitor, this particular drug can reduce the patient's risk of experiencing myocardial infarction, a stroke, and death. So typical ACE inhibitors are going to be lisinopril, which is most commonly prescribed in patients, as well as enalapril, benazepril, and quinapril. And also statins. Our statins, having a high cholesterol along with PAD, further increases the patient's risk of coronary heart disease and also, again, the plaque buildup. So we want to make sure that our patients are having this discussion with their doctor as far as making sure that they are on a high-intensity statin. And a high-intensity statin is based off of the milligram and also the particular agent itself, because there are multiple statins out there, but our high-intensity statins are going to be a atorvastatin 40 or 80 milligrams, and also rosuvastatin 20 or 40 milligrams. So our final thoughts and takeaways from this presentation is that we want our patients to live a healthy life. So we want them to take preventative measures such as smoking cessation if they're a current smoker, exercising regularly because exercise helps to promote adequate blood flow. We want to control our diabetes, hypertension, and hyperlipidemia. And we also want to make sure that patients are eating a healthy diet that is low in saturated fats, as well as maintaining a healthy weight and proper foot care. Does anyone have any questions?
I will give it a few minutes to see if anybody wants to unmute themselves or type in chat. Why not? No one has any questions?
I was just wondering, you may have already answered this, but this is Jennifer. Is swelling and fluid retention usually related with this, or is that something different? And is that why it's not always that detectable? I just think about people with, fluid retention in their legs and ulcers and things like that. Does that all kind of go hand in hand with this, or this is a little less typical of that?
Fluid buildup is less typical with PAD itself. Generally, we're gonna see the muscle pains and colder limbs. That's going to be the most common way to identify it.
Usually,
Great. Thank you.
And hairless legs, Jennifer. The hairless legs are really very interesting. Macy, I don't know if you can see it, but there is a question in chat. On the off chance you can't see it, it just says, under plaque buildup, is sedentary lifestyle considered a problem as well?
Yes. So when a patient has a sedentary lifestyle, if they're most commonly their diet's probably not what we're aiming for. It's probably high in our cholesterol, fats. So when they're sedentary, they're not moving their muscles, they're not getting the heart. What we want to do is keep our heart trained, and so that it pumps the blood from the heart, of course, to the limbs. So that is also a contributing factor. Yes, ma'am.
Okay. Are there any other questions for Macy?
Okay, Casey, this is going to seem like a strange one, but I grew up with a Nana who she was having revascularizations done back like in the 60s and 70s when she was in her 50s and 60s. How long has like Plavix and some of the cholesterol medications been around? Because I don't remember her being on anything for her PAD, but I remember her having several surgeries on both legs where they were what they used to call it stripping veins.
Yep. Macy, do you have any idea? And if not, I'll try to tackle it.
I'm not quite sure, Dr. Baldwin.
Officially, Judy, statins have only been around, I'd say probably somewhere in the, I'm guessing, I can actually go in and dig first, but I believe the first statin developed was called fluvastatin under the brand name Lescal. We don't see it traditionally anymore. It's not as effective. And when I say that's the first statin, that's the first one that hit the market as a statin. The very first statin is in red rice, and it's lovastatin. But officially, the statins as a class of medications have been around since probably somewhere in the 90s, just based upon when the first generic came out.
Okay, that's what I was thinking. You know,
yeah, now, Plavix probably, I would say that generic that was a hot mess. The clopidogrel, which is the generic for Plavix, came out and stayed out 2000. I believe that generic came out officially in 2007, 2008, 2009. But aspirin has been around for ever. I don't have a
yeah, but I don't remember them saying back then to take aspirin, you know?
Yeah, I don't think they did, but a lot of the information on peripheral arterial disease is, gosh, it's changed drastically since I was a student, at least how we treat it. So we've gotten better as a whole about learning how to treat PAD. So your grandmother would not have had a lot of this information, and surgery was some of the easier stuff to do way back when. Not as safe.
Yeah, I remember it was brutal surgery because she would be out of work for, a couple months and then just still really hobbling.
Yep. Yeah. So does that kind of answer?
Yes. As I said, I was just curious.
Yeah, I mean, it's a fair question. It's proof that we're always constantly changing.
Which is a good thing.
Yep. If there are no more questions and I see no more written in there, I'm going to go ahead and say thank you very much, Macy. And
Thank
let
you.
you off the